So, hello everyone, and welcome to this important and interesting session of emergency radiology on imaging of aneurysms, where I'll be discussing few important cases along with their reports. So, let's start with the first case. So, here we have a 20-year-old male who came to emergency department with a palpable painless lump in the epigastric region. This is a very important clinical sign to be elicited, a palpable painless lump. And he gives a history of recurrent episodes of pancreatitis in the past and was clinically stable with the blood pressure and the pulse rate within normal limits. So the clinicians had ordered a USG abdomen for this patient, and I was the radiologist on call. So this is the ultrasound picture of this patient. The probe is kept in the epigastric region, and where here we can see a large collection with a swirling motion, and on color Doppler we can see there is a bidirectional flow giving both red and blue colors. This swirling motion is very well seen along with bidirectional flow, giving a typical yin-yang sign, which is very typical of a pseudoaneurysm. So again, we'll take a careful look at the scan from cranial to caudal direction to trace from which vessel actually the pseudoaneurysm is arising. So we are going from cranial to caudal direction along the course of the aorta. These are the hepatic arteries which are very well opacified. There's a lot of intrahepatic biliary radical dilatation. We'll see why it is. This is the first branch of the aorta, that is the celiac trunk. Then comes the superior mesenteric artery, from which a small vessel is actually arising, which is giving rise to this aneurysm. There's a lot of fat stranding, multiple pockets of collection are seen, a lot of nodes are seen. So the aneurysm was actually arising from the inferior pancreaticoduodenal artery, which is a branch of the superior mesenteric artery. And this is the report I had given, that the pancreas appeared atrophic with multiple calcific foci, and there was a focal well-defined lesion of vessel attenuation which seemed to arise from the inferior pancreaticoduodenal artery, which is a branch of the superior mesenteric artery, particularly seen on the maximum intensity projection images, where the vessels can be very well traced. And then there was surrounding hypodensity around the aneurysm, which was indicating a perianeurysmal thrombus in the head region of the pancreas. And since the aneurysm was actually compressing the CBD, there was a lot of intrahepatic biliary radical dilatation that was seen. Other than that, there was multiple enlarged retroperitoneal mesenteric nodes which were suggestive of inflammation. Impression was a pseudoaneurysm with the perianeurysmal thrombus in the head region of the pancreas arising from the inferior pancreaticoduodenal artery. So for the treatment, the patient was taken to the cath lab and a microcoil was placed within the aneurysm. So this is the pre-coil images where we can see there is extravasation of contrast. And then after coiling, there is no extravasation, and we can see that coil is very well placed within the aneurysm. So what exactly is the pancreatic pseudoaneurysm? Pancreatic pseudoaneurysm develops due to digestion of the vessel wall by the pancreatic enzymes like elastase. Most commonly, splenic artery and the gastroduodenal artery are involved. Splenic artery in the tail region of the pancreas and gastroduodenal in the head region of the pancreas. But inferior pancreaticoduodenal artery is relatively rare, which was in this particular case. Uh, Complications of a pseudoaneurysm include a rupture of the pseudoaneurysm into the peritoneum and the adjacent hollow organs, giving rise to hemosuccus pancreaticus, and rebleeding of the aneurysm following an embolization. To the second case, here we have a 37-year-old male who presented to the emergency with a history of acute onset severe chest pain and hypertensive crisis. Patient gives a history of hemoptysis since 8 months with chest pain and is a chronic smoker and hypertensive. So aortogram was performed for this patient. So this is the post-contrast axial section where we can see that there is a outpouching from the descending thoracic aorta. These are the coronal images where we can see this very well outpouching from the descending thoracic aorta along with peripheral hypodense area, which is indicative of thrombus. These calcifications are the intimal calcifications. These are SAG images. So these are the pictures of this aneurysm that is arising from the descending thoracic aorta. These are the intimal calcifications, and this is the perianeurysmal thrombus. I had given that there was a focal outpouching of the descending thoracic aorta. The size of the aneurysm is very important. The neck diameter is also very important, and the distance from the origin of the left subclavian artery in this particular case as a landmark with surrounding thrombus and peripheral rim of calcification was suggestive of a pseudoaneurysm. There were multiple tortuous collaterals also arising from the descending aorta in the paravertebral region. The patient was managed with TEVAR with endovascular stent graft placement. So what exactly is an aneurysm? The aneurysm is actually a permanent localized or diffuse dilatation of the artery with more than or equal to 50% of the expected normal diameter. Location, commonly it is located in the aortic root and the ascending aorta, then the descending aorta and the arch. And risks of development of an aneurysm include a hypertension or coronary artery disease. So aneurysms can broadly be classified into a true aneurysm or a false aneurysm, saccular aneurysm or a fusiform aneurysm, congenital aneurysm versus acquired aneurysm. So true aneurysm includes all the layers of the arterial wall, while false aneurysm, which we have seen in both the cases, have only a single layer of the uh, vessel wall surrounding it. Saccular aneurysm arises from a distinct portion and has a mouth, as in this particular case, while a fusiform aneurysm involves the total circumference of the artery with no distinctive mouth. Congenital versus acquired is more frequently seen. So this is very important slide as to what are the signs of an impending rupture or a contained leak. So most aneurysms show progressive enlargement with rate of growth being greater for aneurysms of the descending thoracic aorta than the ascending thoracic aorta, and larger the aneurysm, the more rapid is the growth according to the Laplace law. So diameter of the aneurysm is the best predictor for rupture risks. Hence, in all the cases of an aneurysm, it is very important to give the size of the aneurysm. Other parameters include the type of aneurysm. Saccular aneurysms are more prone to rupture as compared to fusiform aneurysms. And other risk factors like hypertension, smoking also increase the risk of rupture. Then the signs of impending rupture, which have to be seen on any imaging, include a draped aorta sign, which is indicative of a contained rupture of the aneurysm, high attenuation crescent sign, thrombus fissuration, focal discontinuity of the intimal calcification, and tangential calcium sign. Important slide showing the signs of impending rupture and contained rupture. This is actually a draped aorta sign. The aneurysm is actually ruptured posteriorly, but it is contained within the prevertebral space here. There is no this discontinuity of the intimal calcification which is seen here. So this aneurysm is actually ruptured posteriorly. This is the tangential calcium sign. These both the pictures depict the tangential calcium sign. The intimal calcification is directing outwards, which indicates the site of rupture of the aneurysm here. This is the hyperdense crescent sign, indicating impending rupture of the aneurysm. If this particular sign is seen, it is very important to give it in the report so that the clinician is well aware that the aneurysm might rupture anytime. This is thrombus fissuration sign. This is again the tangential calcium sign. Then coming to the etiology of uh, aneurysm formation, most common being atherosclerosis in 70 to 80% of the cases. Then cystic medial necrosis in case of Marfan's and Ehlers-Danlos. It can be mycotic or infective aneurysm. It's usually saccular in nature. It can be because of vasculitis, and it can be post-traumatic as well. Male who presented to the emergency with complaints of abdominal distension since the past 5 days along with blackish discoloration of the flanks. He complained of anuria since the past 2 days now, and patient was morbidly obese with a history of chronic hypertension. The blood pressure was 90 by 60. This patient was hypotensive. And on ultrasound, which was done outside, it revealed a ruptured abdominal aortic aneurysm. So emergency CT scan was done, and this particular patient. So we'll be tracing the aorta. So as we go along the course of aorta, we see a lot of perinephric fat stranding, a lot of mesenteric fat stranding, and retroperitoneal collection is also seen with edema. And at the bifurcation of the aorta, on the right side, there's a large aneurysmal dilatation of the vessel, along with retroperitoneal hyperdense collection that is seen. On these axial images, extensive fat stranding and edema is present. These are the coronal sections, where we can see that at the bifurcation of aorta, there is outpouching, abnormal outpouching of the vessel from the right common iliac artery, along with hyperdense retroperitoneal collection. These are the post-contrast images, axial section. Trace the aorta here again to look for the origin of the aneurysm. Lot of fat stranding and edema is present, and here, as the aorta is actually bifurcating into the common iliac artery, there is a large outpouching that is arising from the right common iliac artery, along with some thrombus and retroperitoneal collection and contrast extravasation that is seen, which is a sure shot sign of a rupture of the aneurysm. Extensive para-aortic fat stranding, perinephric fat stranding, contrast extravasation, outpouching from the right common iliac artery. So this picture shows contrast extravasation along with the outpouching and para-aortic fat stranding. So the signs of frank rupture include a retroperitoneal hematoma, para-aortic fat stranding, and contrast extravasation on the aorta into the retroperitoneum. All the three were present in this particular case, indicating a frank rupture. So there was abnormal fusiform dilatation of the right common iliac artery, starting from the bifurcation of the abdominal aorta to its bifurcation. There was a large peripheral mural thrombus surrounding the lumen with contrast extravasation and thrombosed blood into the retroperitoneum, indicating rupture of the aneurysm. The diameters of the sac were given, and the wall of the abdominal aorta appeared edematous after the origin of the renal artery with adjacent fat stranding. So what exactly is included in the acute aortic syndrome? So the four important entities that are included in acute aortic syndromes are the aortic dissection, acute intramural hematoma, penetrating atherosclerotic ulcer, and ruptured aortic aneurysm. One of them we have already discussed in this particular case, that is ruptured aortic aneurysm. The rest, what are the differences? So this is a very important slide showing the acute aortic syndromes. So here we can see that there is blood within the tunica media layer of the vessel. This is the intima, this is the media, and this is the adventitia, and we can see that there is blood within the tunica media layer of the vessel with no intimal flap as such that is seen. So basically this blood is actually arising from the ruptured vasa vasorum supplying the tunica media. So this is called intramural hematoma. On imaging it looks like this, intramural hematoma, that is blood collection, hematoma within the intima layer of the vessel wall without any intimal flap. So this is atherosclerotic plaque, and eventually it ulcerates. It causes ulceration of the intima and the blood goes into the media layer, and this is called penetrating atherosclerotic ulcer. As we see here in this particular case, the intimal calcification is discontinuous here, along with uh, some blood within the media. So this is the penetrating atherosclerotic ulcer, and this is intramural hematoma. Aortic dissection, intramural hematoma, and a penetrating atherosclerotic ulcer. In aortic dissection, in dissection, we can see an intimal flap, very well seen. In intramural hematoma, it is actually the rupture of the vasa vasorum supplying the media, and hence there is no intimal flap that is seen. And in penetrating atherosclerotic ulcer, the plaque actually ulcerates through the intima and then involves the media. So coming to the fourth case, here we have a 17-year-old male who presented with history of injury to the right arm with a sword and complains of tingling and numbness in the right hand. On examination, the right radial pulse was feeble and a CT angiography was done for this patient. So this is the post-contrast images. When we see the brachial artery here, there's a focal outpouching from the brachial artery that is seen in these post-contrast images. And these are the VRT images where we can see this focal outpouching from the brachial artery. This is a report that was given, a large contrast-filled cavity, noted lateral to and communicating with the right brachial artery, suggestive of a traumatic pseudoaneurysm of the right brachial artery that was seen. So what are the take-home messages from this particular presentation? These are the head of the pancreas. We have to think of pancreaticoduodenal artery aneurysm as well, along with the gastroduodenal artery. And the complications of pseudoaneurysms are to be kept in mind while reporting any case of pseudoaneurysm. Signs of impending or frank rupture are always to be looked for in case of any aneurysm. An acute aortic syndrome spectrum has to be kept in mind along with the differences. Thank you.